Ladies and gentlemen, Mr. Chairman, first of all, I want to thank for the kind invitation and congratulate all the speakers before me for their excellent presentations. It's really an honor for me to be part of this group this afternoon. I'm from Hamburg and I work at St. George Hospital, which is one of the oldest hospital institutions in Europe, and we are located directly in the center of the city of Hamburg at the water, and we're getting a lot of emergency cases from that whole metropolitan region that comprises about 5 million inhabitants. Now, last year our group has published a paper on bleeding complications after use of novel oral anticoagulants in patients undergoing cardiac surgery. And from that retrospective analysis, we concluded that despite official recommendations, patients should not, whenever possible, be considered for elective cardiac operations within 10 days of NOAC withdrawal. During that research, it was the first time for me that I really longed for a method to remove or extract drugs that cause major bleeding from the human blood during open heart surgery. And I want to show you that with the CytoSorb, we have such a method. Since the time of the first stent implantation, stent thrombosis has been a serious problem in PCI patients. So the evolution of PCI, and here you see the data from Germany, the evolution of PCI is still going on over the years, has also been an evolution of antiplatelet therapy after PCI. I think you know this figure, and there was one very important trial, the Plato trial, that showed us how effective Ticagrelor is compared to clopidogrel. Both drugs showed major bleedings, okay, and I was really surprised that the recent investigation on Ticagrelor showed that it is inferior to prasugrel for reducing ischemic events. Anyway, Ticagrelor is a very frequently given P2Y12 receptor antagonist. It has a direct acting, does not require metabolic activation, has a rapid onset, and it shows something very useful, a high degree of protein binding. Now, the 2017 ESC Guidelines for STEMI patients, they recommend to give such a potent P2Y12 receptor antagonist at latest at the time of PCI. So what happens when such a patient goes to the OR in the end? He or she has a high incidence of major bleeding complications with this almost 40% on the first day and 25% or more on the second or third day. So whenever it's non-emergent, then time is a really good antidote, like these authors recommend. Just wait 3 or 4 days. But what shall we do when it's real emergency? I think it was in April or May 2017 that this experimental research was published that showed that the CytoSorb is able to remove Ticagrelor from the human blood. What CytoSorb is, what it can, we have heard this. It uses a high-tech polymer technology. It has a big surface, and it is able to remove medium-sized molecules. Now, the first time we used it was in June 2017, and I had to operate on, it was a Friday evening, on a type A aortic dissection, and it was a young patient, and he was freshly loaded with Ticagrelor after PCI for the circumflex artery, and I still remember it as if it was yesterday. We had a short time to talk to that patient, said, man, this is really high-risk surgery, and it's even more risky because you have taken that drug and we have to do something. And this is what perfusionists of us made a drawing and said, we take that CytoSorb and put it into the heart-lung machine between the venous reservoir and the oxygenator in that small circuit and try to remove the Ticagrelor from the blood. The patient agreed. And this is the setting now we used and we published. And when you are interested in the details of everything, you would like to invite you to have a look at our paper that we published on this. This is another image after cardiopulmonary bypass. It's from the local journal. We published this in Hamburg. Now, let's look at these 43 patients. All patients underwent emergency cardiac surgery at our institution between June 2016 and June 2018. It was a retrospective single-center analysis, and 32 of these cases had that CytoSorb adsorption that we first used in June 2017. In other words, we had a very small control group of only 11 patients done the year before, but same surgeons, same procedures. Now, is there a blood test to validate effectiveness of such a method? Now, there is that Multiplate analyzer that offers the possibility of a rapid determination of platelet function, sense of a point-to-care investigation. It's that small machine, and upon activation, platelets aggregate on metal sensors, as you see it here. So when the method works, we see a nice increase of that levels. Now, during that period, we didn't have that Multiplate, so we will have it in the future. But during that time, we took the blood from only 5 patients and gave it to another institution. So this is really a small data set, but I think it's interesting enough to give the information to you today and maybe discuss it later. Now, let's first look at the baseline characteristics of these patients. Now we have that CytoSorb group, 32, we have that small control group, 11 patients. All were true emergency cases and all had an underlying coronary artery disease. And the first thing we realized in that retrospective analysis was that we had saved operation time with the CytoSorb, more than an hour, and we had saved red blood cell transfusions. 78% did not need any blood cell transfusion, and the reason is they bleeded less. Here you see the drainage volume of that patient over 24 hours, and you see aggressive bleeding without adsorption, and you see more or less normal blood loss in that CytoSorb group. The mean value was 350 milliliters, and we all know this is normal after CABG. And there was no reticulotomy in that group compared to 4 of 11 in the other. We had a short ICU stay, and we had a shorter total length of stay. Now, patients done with adsorption did not need any platelet transfusion in half of the cases, and when they needed, they only needed 1, compared to all of the patients done without adsorption, and half of them needed 2 or more platelet transfusion. Now let's look at that very small data set of the Multiplate patients. Here you see something very familiar, the platelet counts pre and post cardiopulmonary bypass. You see a decrease of the values, which is normal. But you see when you look at patient number 4 that he had a decrease below 100,000. And that was the only one who did not show a nice increase of the values in the multiplate. He showed a decrease. And this was the only one of this group who had a really high drainage volume afterwards. And the truth is, we don't know why. He was old, okay, he had low platelet numbers, okay, but maybe albumin was loaded with other drugs or the adsorption came upon against limiting factors. We don't know. This is only one of the open questions. The other is the duration time of adsorption to fully eliminate the drug from the body is unclear. And what about the effectiveness in NOAC patients? Some NOAC have protein binding too. Now this is a figure from our graphical abstract from our publication, and here you see in number of 55 we included 12 patients who were operated under rivaroxaban. And when we now look at that figure of the drainage volumes, you see here Ticagrelor, you see here rivaroxaban, almost the identical figures. So the rivaroxaban patients showed less bleeding. Recently, removal of dabigatran has been shown in an experimental study some weeks ago. And another interesting paper is that a reversal agent for ticagrelor has been tested in a phase 1 trial. I think in a few years we can use it, but I guess it will be expensive. So let's talk about costs. A budget impact analysis was done of that small data set. We saw improvements, we saw decreases. Is it cost relevant? Statistical analysis was done, including a bootstrap analysis for calculations of costs. And two things we identified. The cost of ICU stay had the highest impact on level of cost savings, as you can see it here. And the other was that adsorption generated savings calculated as about 3,700 euro without reimbursement. So when you reimburse the adsorber, it's maybe 5,000 or something like this. So we saw both medical and economic benefits of the CytoSorb by reduced operation time, faster discharge, generally improved patient blood management. Of course, there are a lot of limitations. It was a non-randomized observational study of a single center, what really limits the breadth of conclusions. We had only 55 patients, and the control groups were small, as I mentioned. So definitely, prospective investigations are required, and this is what we are going to do with the support of experienced other centers. And the protocols are written, we just have to give it to the ethics committee, and hopefully we can answer more of these questions in the near future. For now, for today, the adsorption method has become our standard procedure in patients loaded with ticagrelor and also rivaroxaban. And finally, I want to show you one more case. I think you see on one glimpse what had happened. It was a young woman with a coronary artery disease of that big right coronary artery, and what happened was a dissection during PCI, and the patient was loaded under ticagrelor. But in that case that I operated on, I felt so much more comfortable and confident because I knew that we now overlooked 61 patients done with the adsorber, and we had only one retorcotomy among them, and that was a real surgical bleeding, a detached clip, and the ICU stay time was so short. So I can only encourage you to make your own experience with this. I think you will really like this method. Thank you very much for your attention.